Should I start then?
I'm just going to do a quick introduction, then you can start.
Cool.
Once we're live. Hi, everyone. Thank you for joining us for this tutorial. So today's tutorial is an AFP one. So it's the first session of the Journal Club. It's given to us by Dr. Yang. So just a few rules. If you're watching via Zoom, any questions or comments that are covered in the moment, if you just want to pop into the chat, and any question that can wait to the end, if you just want to pop into the Q&A. If you're watching on the Facebook Live, if you just leave your questions, your comments, and I'll pass them on to the tutor. That's all from me now, and I'll hand over to Dr. Yang. Thank you.
Hi there, everyone. My name is Yu-Hsuen. I'm a Foundation Year 1 doctor in Queen's Hospital in London. I'm currently doing the Medical Oncology AFP as part of the London AFP. So, for anyone out there wanting to kind of apply to the London AFP, I'm more than happy to take questions at the end as well. I just wanted to get a quick kind of a survey of like everyone who's here. If you could just, type out your name and what you're doing at the moment in the Q&A. At least I know who I'm like going to be speaking to. At least I can, I guess tailor my presentation a bit more. Sorry that this is not going to be as interactive as, oh, amazing, great. Hi, Jack. I guess because this is a journal club, I would have kind of liked it to be a bit more interactive, but I guess because this is a webinar, I won't be able to kind of gauge your responses verbally. So it'd be really helpful if you could just put your responses in the Zoom webinar chat, and then we can discuss from there. What about everyone else? I can see that we have, I guess, 8 participants. We've got Aaron, Chanel, Debbie, Kantida, Olamide, is that correct? Oh, okay, fine. I can like see, I think I should be able to have you guys speak actually. So if you want, you can unmute your mics and introduce yourself. Are you guys able to unmute your mics or anything? I think I've allowed people to participate in the chat, so.
Hello.
Hello, hello. Oh, great, that's fantastic. Yeah, anyway, I'm just gonna proceed forwards. So if you want to, during the webinar, answer any questions or ask any questions at all, feel free to unmute your mic. The aim of this journal club really is to have an informal chat about an abstract that I'll be putting up. There are some questions that I have kind of put into the presentation for you guys to answer. I think if you are applying to the London AFP, it'll be very much, what you'd the questions you'll be getting here are very much similar to what you'd be expecting from the London AFP interview. So for the London AFP, you have a critical appraisal kind of station where they ask you a set panel of questions. I think for the Oxford and Cambridge AFPs, you may be asked to discuss an article that you've read that you found interesting. But I think for the London one, it's a bit more structured and, they ask you set questions. So we'll just run through a few of them as well. So without further ado, I'll just start. So just a disclaimer from Becoming a Doctor. Some learning objectives for this short webinar are to be able to briefly summarize an abstract using the PICO structure. Does anyone know what PICO is? So PICO stands for, population intervention control outcome. Fantastic. Yeah, I can see that on the webinar chat. Another learning objective is to comment on the internal validity of the study, which is the study design and how well the study minimizes bias in itself in the way that is designed. The third objective is to comment on the external validity of a study, which really is the ability of a study to be generalized to an average population. The fourth learning objective is to learn to comment on the ethical aspects of the study. And this is something that I think for the London AFP, I got asked about. And they do like to ask quite a lot about ethics within the context of the interview as well. So the final learning objective is to discuss the clinical implications of the study and whether or not you would use it to shape your clinical practice. And that, again, is a big focus of many interviews, including the London, Oxford, and Cambridge AFPs. All right, so the study we'll be looking at today is the Scott trial. It was published in The Lancet in 2018 by Yu-Hsuen et al. You can use the URL available here. Alternatively, I've put the abstract up, so I'm not sure if you guys can see it. But I'll give you, I don't know, hands up how many of you have actually read the abstract before the session. Okay, so quite a few people, but for those of you who haven't had the time to read it, maybe let's spend about 5 minutes quickly glancing through it, if that's all right. So I think for the AFP, the London AFP kind of critical appraisal station, you get 30 minutes to appraise, 30 minutes combined to appraise both the, I think, clinical vignette as well as the abstract. So the way I would split it really is if you were, I mean, I'm not sure what the structure of it is like this year, but the way I split it was 20 minutes for the abstract and then 10 minutes for the clinical station. It's really down to you to prioritize which one you would spend more time on, but it typically takes a lot longer to appraise an abstract. I would recommend that when you go into the station, when you get the abstract, you have a pro forma, so to speak, of like things that you'd be looking at. So comment on, kind of do a quick summary, comment on the internal validity and have a structure for that, the external validity, some elements on ethics, and whether or not it would shape your clinical practice. And these are some of the questions I'll be running through during the session. Don't know if that's helpful. Is that what you would expect? Is that going to be useful for you guys? Okay, great. All right, hands up for those of you who are comfortable with moving forward. Okay, I can see 4 people have raised their hands. Who needs a bit more time to read through the article? Okay, so just one person needs a bit more time to read through the article. So let's spend maybe about 2 more minutes and then we can move on. And oh yeah, sorry, I forgot to introduce myself as well. But really, just a brief background. I was at UCL as well. I did both my undergrad and both my preclinical and clinical placements at UCL. Took a year out and did a master's in programming, and then returned back to UCL for my 5th year of clinical studies, and then applied for the AFP. I want to do medical oncology, so if anyone is interested in medical oncology out there, let me know as well. Okay, great. So I'm just going to move on to the questions that we, will be discussing during this session. Okay, so we'll discuss 5 questions really. So first of all, briefly discuss the study. 2, please comment on the strengths and weaknesses of the study. Design. 3, please comment on the ethical elements of the study. 4, question 4 is a bit more about how you would explain this study to a patient and focusing on simplifying the study in a way that patients can understand. There may be a lay member of the community in your interview in some of the other deaneries. So I think for Oxford or Cambridge, you may have a lay member who you might need to explain the abstract to. And 5, whether or not this trial would change your clinical practice, all right? So I think let's just try and keep this interactive. Can someone briefly discuss the study and summarize it for me? So I can see that we have Bridget, I think Bridget's running the session, Grace, James, Cantida, Olamide, Jack, Chanel, Debbie, and KL. Does anyone want to volunteer to summarize the study? I can see Tash as well. And Ian?
I can do it.
Okay, brilliant. Thank you. Do you want to give it a go?
Yeah, so this abstract is entitled 3 versus 6 months of adjuvant chemotherapy combination for colorectal cancer. And the population studied was 18 years or older with high-risk stage 2 or 3 colorectal cancer requiring adjuvant therapy. The intervention group have 6 months of adjuvant oxaliplatin-containing chemotherapy, whereas the control group had 3 months of the same chemotherapy. The primary outcome measure was disease-free survival with a non-inferiority margin with a hazard ratio of 1.13. And
okay,
what
that's really good.
Was that the 3 months chemotherapy was non-inferior to 6 months, the same therapy.
Yeah, that's really good. I think that's really how I would do it, to be honest. So when you summarize the study, I would say, you state the title in your own words. So I would say this is an international randomized phase 3 trial comparing the efficacy of 3 versus 6 months of adjuvant chemotherapy with oxaliplatin fluoropyrimidine combinations. So just a bit of context for those of you who may not be familiar with it. Adjuvant chemotherapy is typically given after primary resection of the tumor. So it's given after surgery to reduce micrometastatic deposits and to reduce recurrence, as well as prolong survival as well. Then I would essentially break down the study using the PICO structure. So I would say the study was done in a population of 6,088 patients aged greater than 18 years of age with high-risk stage 2 and 3 colorectal cancer, which Jack, you did very, very well in summarizing. The intervention compared was 3 months of adjuvant oxaliplatin fluoropyrimidine combinations against the standard of care, which was 6 months of adjuvant treatment. And in terms of the outcomes, the study examined the primary outcome of 3-year disease-free survival and the secondary outcome of adverse effects. So the primary outcome and secondary outcomes. The primary outcome, does anyone know what that is compared to the secondary outcome? Can we have someone, maybe Chanel?
Hi, can you hear me?
Yeah, I can hear you, yes.
So the primary outcome, that would be what the study is trying to find out. So that's their I guess, their first outcome they're looking at. But for the secondary interventions, that's more extra things. So it can be things like side effects, anything else that they want to look out besides their main aim.
Yeah, that's right. So that's completely correct. And actually, the primary outcome is what the study is powered to identify or study. Does anyone know what power means? Let's maybe have Cantida.
So what I understand by the power of the study is, so they calculate like the amount of sample size that needs to be used so that it would generate a statistically significant result.
Correct. That's exactly it. But really, the power of a study is the ability of a study to discern a difference where one exists. Okay, so that's essentially the statistical definition of power. So the primary outcome of a study is really what the study is powered to detect a difference in. I hope that clarifies things. So yeah, I think the way you would summarize a study really is if, say, an interviewer says, please summarize the study for me, you would state the title in your own words and then use the PICO structure to break it down. And then briefly summarize the study, what the study found. So I think in my own words, really, I think the study found that 3 months of adjuvant chemotherapy was non-inferior to 6 months of treatment and also had fewer side effects. And when I say non-inferior, I mean non-inferior in terms of the primary outcome of 3-year disease-free survival. So I hope that helps. Any questions so far? Is that all okay? Okay, great. All right. So let's talk a bit about internal validity. So can someone comment on the strengths and weaknesses of the study design, i.e. the internal validity of the study? Now, just for clarity, the internal validity of a study is how valid a study is in terms of minimizing its biases, which is, how well the study is structured or designed to answer the question at hand. So does someone want to talk us through the strengths and weaknesses of the study design? So just imagine this was kind of an interview that you were in. Let's say, Lamide, do you want to talk us through it? Or maybe someone else, I don't know, like Ian? Yu-Hsuen, is that the way to pronounce it?
Hi there. Yeah, it's Yu-Hsuen.
Yu-Hsuen, okay, sorry about that.
That's okay, that's okay.
Would you be keen to talk us through the study design and the strengths and weaknesses of it?
Yeah, of course. I must apologize in advance. I haven't actually read the journal because I thought we were going to go through it this evening, but I'm glancing through it now, so I can try and attempt to make a comment on the internal validity. So I guess...
Okay, to be honest, it doesn't really matter that much. The aim of the session is meant to be an informal chat, but also to give you an idea of what to expect in the interview. But yeah, go ahead.
Okay, so we're trying to sort of ascertain, has there been sort of an adequate internal standard to see whether we can truly believe the result of the study? So I think the internal validity is relevant because when we look at sort of the randomization of patients, we can see that randomization was done, which sort of increases the internal validity in itself. But the use of sort of minimization algorithms definitely helps to raise the internal validity of the study. And sort of we can sort of be confident that the authors have tried to reduce the extent of sort of randomization bias, and by using sort of allocation concealment, that's definitely one sort of positive to take away from the randomization process.
Okay, that's great. Do you know what the role of randomization does? Well, I mean, do you know what randomization does in terms of reducing the bias of a study?
So from my understanding, the purpose of randomization is to make sure that we have sort of a similar baseline demographic between the two populations at hand, and that there are no sort of significant differences between the two populations before starting or implementing the intervention. So by the use of randomization, we are giving sort of patients the option to go into the intervention arm or the control arm, but they won't be aware of which arm that they're going into, and this helps to sort of reduce the selection bias.
Yeah, that's really good. So just to summarize, the role of randomization is, in brief, to create broadly equal populations between the intervention and control group, for which you can compare. For which you can compare the intervention and control in a broadly similar manner. What randomization does is it reduces the risk of confounding. So some of the confounders in this study were, the stage of colorectal cancer, because they looked at both stage 2 and 3 colorectal cancer. So, some of the confounders would therefore be the tumor stage, nodal status, where the disease site was at. So whether it was right-sided or left-sided colorectal cancer, sex, male, female, choice of regimen, so either oxaliplatin, fluorouracil, or K-POX, which is capecitabine, oxaliplatin, and also the center. So really, these are all kind of confounding factors. Does anyone want to explain what a confounding factor is? So let's say Tash.
Hello, hi, can you hear
Hello.
me?
Yes.
Okay, I don't know what the textbook definition is, but I can give a flavor. So like a confounding factor is a factor that might have an effect on the outcome of the study, but it's not something that you're measuring. So it's something on the outside. It can affect the outcome, and it can affect the treatment as well that you're giving, or the intervention as well. But it's like it might give you like a false result, basically.
Correct. Yeah. So really, it is a variable that has a triangular relationship with the cause and effect. So, for instance, in this context, let's say tumor stage. It may be that tumor stages tumors which are larger, individuals would typically be treated with, for instance, FOLFOX rather than K-POX, and that might have an effect on the overall survival as well. Okay. So yeah, randomization. One of the strengths of the study was that it was a randomized controlled trial, and randomization reduces the effect of confounding factors, and also creates broadly similar groups between the intervention and control. Does anyone else want to volunteer a strength of the study?
So one of the good things is that the study used an intention to treat analysis.
Oh, great!
And, yeah. This reduces the attrition bias to the study.
Yeah, that's really good. So does everyone know what intention to treat analysis entails? So Kantita, since you brought that up, do you know what does intention to treat analysis really mean?
So from what I understand is that it's like a method for analyzing results where you include all the participants, even though they drop out or if they don't comply to treatment, because it reflects real practice better.
Correct. It's exactly it. So basically, all subjects, whether or not they dropped out or not, are included in analysis. And intention to treat analysis essentially avoids attrition bias, which is bias which arises from what happens when you have patients drop out and aren't represented in the eventual outcome if you use the per protocol analysis. And the advantage of intention to treat analysis really is that the study results tend to mirror results seen in clinical practice, because you're really accounting for individuals who would typically drop out, for instance, due to side effects, due to non-compliance, etc. The opposite of intention to treat analysis is per protocol analysis. So per protocol analysis only analyzes the outcomes for individuals who continue through with a specific intervention. So what you would end up having is maybe an exaggerated effect of how efficacious the therapy might be. Does that make sense so far? Okay, so I'll take the silence as a yes. So we've talked about two things. So randomization, or the strengths of a randomized controlled trial, and intention to treat analysis. I've come up with a few kind of strengths that might be, I guess, strengths of the study. I just wanted to, before we go through kind of the what I put down, does anyone think that the study has any weaknesses, or does anyone want to know a bit more about the study before commenting on the internal validity of it? So maybe let's have Josie. Or maybe let's have, I don't know, whoever wants to volunteer really.
I'm not really I'm not sure if this is if it's in there somewhere, but does it say anything about blinding? Because there wasn't, I don't think there's anything to do with blinding there, but I don't know if it's relevant or not.
True. What do you think about blinding in the context of the study? Do you think it's possible to blind the investigators or the participants?
Sorry, I haven't actually read it completely.
I think given that it's unlikely to be blinded just because one have 3 months and one have 6 months. So it's not blinded at all.
Yeah, I think it would be quite difficult to necessarily blind the investigator in the study. So whoever's looking at the study, it'd be difficult to blind the person who's collecting the data or administering the treatment. But maybe for the patients, you could give a placebo for 3 months and compare 6 months of therapy with 3 months being the actual intervention or chemotherapy combined with 3 months of placebo against an individual who gets 6 months of chemotherapy. But I think in the context of the study, it is, like you said, Jack, quite difficult to blind the participants. So I guess there is a reason why they haven't mentioned blinding, probably because they haven't managed to blind both groups. But I think you probably would want to read the full paper and see what they did with that. Would anyone want to know a bit more about what they did in the study? Or does anyone want to comment on some of the weaknesses of the study?
I guess I'll make a comment there. That's okay. So I'm not sure if the inclusion of participants, was it sort of in a consecutive approach, or how it's not very clear how the patients were recruited to the study. They might be sort of recruited consecutively, which would definitely strengthen the nature of the study. But likewise, there's no mention, and it could sort of introduce an element of selection bias into the equation.
Okay, why would serial? I didn't quite get that actually. Why would serial kind of recruitment help?
Because if you think about it from sort of first principles, if you're just picking in candidates as and when, there might be sort of a sort of subconscious sort of bias to select patients who you think that would benefit more from this sort of trial. Whereas if you take a generic approach and sort of introduce all patients into the study, regardless of sort of their disease status, that would reduce the selection bias.
Okay, I see what you mean. Yeah, that's a really good point. I think some of the things I had thought about as well in terms of looking at the population is you would want to know in terms of the distribution of the individuals across centers. So whether or not the study was heavily weighted towards one or two big tertiary centers. So for instance, if you had about half of the patients recruited from 2 centers, that might limit the external validity of the study or the generalizability of it. The other thing you would probably want to be thinking about is whether I would be keen to know how many of these stage 3 colorectal cancers consisted of, for instance, T3 tumors versus T2 tumors, whether or not the study was weighted towards more advanced kind of stage 3 cancers or less advanced ones. I think there's been no mention of whether the inclusion or exclusion criteria for the study, other than the fact that they were, aged 18 and above and had, high risk stage 3 colorectal cancer. I would probably want to know about the definition of what high risk colorectal cancer would be. For instance, what the nodal statuses were. So those are just some of the things I'd probably want to know a bit more. I wouldn't say those were obvious weaknesses of the study, but I want to read the full paper to get a better idea of these things in terms of the population, the study population. One of the other things I was thinking about was, why was the primary outcome, if we're talking about outcomes using the PICO structure, right? So we talked about population. We briefly talked about the intervention and how there wasn't really any kind of blinding. When we talk about the outcome, like I would want to know why overall survival was not studied as compared to disease-free survival, which was the primary outcome here. Most oncology trials seem to look at overall survival. So disease-free survival is really the time to probably recurrence versus the time to death. It makes sense in the context of the study because you would want to see whether adjuvant therapy reduces recurrence, but I think the study could probably have studied overall survival as well. Don't know if that makes sense. Okay, any other comments on the internal validity of the study?
I guess they only followed up for 3 years, if I understood correctly.
Correct, yeah.
So they could have followed up for longer.
Okay. Yeah, that's really good. So I think probably, when we'll go on to this, this is probably an interim kind of analysis. It looks like they're continuing to follow up the patients. So maybe, because the study was sufficiently, or at least the outcomes look in terms of disease-free survival were evident at 3 years. That's why this was reported as it was. But yeah, I do think that maybe it'd be more important to follow up in the long term because realistically, in clinical practice, oncologists follow up the patients for about 5 years before discharging them. So definitely, I think that's something you could comment on. You could definitely comment on the fact that, maybe they could have followed up for a longer time as well. And the great thing about the longer follow-up is that it does increase the power of the study to detect a difference. So I think over here, they said that the study was, I think if you look at the interpretation, you can see second line that despite the fact the study was underpowered, so they did acknowledge the study was underpowered, but probably the study was powered to detect the difference if, follow-up had been 5 years. So follow-up is definitely something you could comment on in terms of the internal validity of the study. Does that make sense?
I actually have a question.
Yes.
About how K-pox or FOLFOX was chosen before randomization, and they didn't mention how the patient and the doctor choose which regimen to follow, and also together with your point about what the distribution is between the 2 regimens.
Yeah, that's really good. Okay, so I think that is a strength in itself and also a disadvantage. So I think there will be some element of procedural bias in terms of, or treatment bias in terms of physicians choosing the treatment they think would be effective for said patient. Just for a bit of clinical context, really, if you compare fluorouracil and capecitabine, capecitabine is really the prodrug to fluorouracil. So it's metabolized in the liver and broken down to fluorouracil. Typically, patients who have any kind of hepatic metastases are suggested to have fluorouracil instead, because they don't want an individual to have their liver taxed by capecitabine or the metabolism of capecitabine into fluorouracil, which might occur in more advanced disease with hepatic metastases. So that's definitely something that could be called into question in terms of the design. There may be some procedural bias there. The advantage of having the patient choose, however, is also, from an ethical point of view, which we'll go into, its advantages because it respects patient autonomy. So that would be a strength of the study, I think, overall. But yeah, good point in terms of pointing that out. Okay. Is everyone okay to proceed forwards?
I just had a point.
Oh, yes, absolutely, yeah.
I'm not sure how relevant it is, but because RCTs can be quite expensive and time consuming, will we take into account the body that researched it, help fund the RCT? Because that might lead to publication bias.
Correct. So I think I didn't paste this in the abstract that I have here, but I think if you look at the funders, you'll see that the study was funded by the Medical Research Council, Cancer Research UK, the Swedish Cancer Society, and NETSCC. So all of these are kind of public research bodies, rather than kind of so-called pharmaceutical companies. It suggests that, it's not always the case, but usually public research bodies tend to have less vested interests in the results of a study. You could argue that on a population level, delivering 3 months of adjuvant chemotherapy would be a lot more practicable and also cheaper for a governmental body, which is why they might be biased towards publishing a study which says both of these treatment durations are equally as effective. But I think overall, based on the funders, it's unlikely that there would be some level of publication bias as opposed to the funders who are a pharmaceutical company. But again, that's a really good point and something that you should definitely consider when you're reading an article. Look for the funders at the bottom of an article. Is there anything anyone else wanted to point out? I think there have been some very, very good suggestions so far.
I'm not sure if this has been mentioned already, but if you look at the chemotherapy regimens, one obviously they both consist of oxaliplatin, but one consists of capecitabine and one consists of a bolus infused with fluorouracil.
Yeah.
I was just interested to see if that in itself was making a difference to the study, depending on whether they received more of the capox compared to the folfox in each group.
Yeah, I think that's a good point. So as I mentioned, capecitabine really is a prodrug to fluorouracil. So from a pharmacological point of view, they're broadly equivalent, other than the fact that capecitabine needs to be metabolized and typically is given to patients who have a better performance status. The other thing that the study has done is that they've actually randomized and controlled according to choice of regimen. So probably in the 3-month group versus with the 6-month group, there have been comparable numbers of individuals who have received both capecitabine and fluorouracil. Now, what you're talking about is a subgroup analysis looking at whether survival has been better with K-pox versus FOLFOX, right? Correct me if I'm wrong.
Yeah, you're correct.
So yeah, that would be quite interesting to see, looking at the subgroup kind of analyses. Again, the danger of subgroup analyses is that the study is not necessarily powered sufficiently to detect differences in subgroups. If they did increase the follow-up time, that would increase the power of the study to detect a difference. Or if they did increase the number of individuals in the study, but we don't know, whether or not there was a difference from this abstract. That is a good point as well. I would say also probably just in terms of, since we're talking about it, I would be interested to see if in the paper they had controlled for both bolus and infused fluorouracil. So whether or not the bolus versus the infusion made a difference. essentially a bolus is when it's given stat versus an infusion, which is given at a low dose over time. All right, so let's move on. I've come up with a table really. So I think when you comment on the internal validity, say you get an abstract, I would I guess create a table with I guess six rows and 2 columns. So one of the columns would be the strength of the study in that aspect of comparison. And the other column would be a weakness, or the things that you don't really know from reading the abstract, or the unknown variables. And then the rows I look at are the study design, the population, intervention/control, outcomes, bias, and statistics. So let's go through each of these in turn. So I would say the strength of the study is that it's a randomized controlled trial. You can comment on the hierarchy, like how high up the hierarchy of evidence based on the CEBM, which is the Center of Evidence-Based Medicine hierarchy it is. So the higher up, a study, the more valid it is really, because for instance, randomized controlled trials, which are interventional and prospective, are definitely a lot more valid than, for instance, a prospective trial. That, for instance, as compared to an observational study, which is not temporal, for instance. So you don't really know whether something is a variable related to another, whether they're related through correlation or causation, as opposed to a randomized controlled trial where you can identify causation. And you can probably comment on whether the study design was appropriate for the question being posed. And I would say an RCT is definitely an appropriate study design for comparing 2 interventions. Then you move on to the population. So I would say that one strength of the study was that it was a multi-center study spanning many. It's a multi-center study spanning 244 centers, which is pretty impressive actually. If you're thinking about logistical requirements of coordinating a study like this. It's got very large sample size, 6,000 people. However, some of the weaknesses or unknowns I would comment on are that, it was acknowledged that the study was underpowered. I suspect that this was because it was reported earlier than the study was conceived for. The other thing I would comment on is why a hazard ratio of 1.13 was selected. So if you look at the article, I'm not sure if you can find it online, but I think the inferiority margin selected was 1.13. So let me see if I can annotate it here. So 1.13. Yeah, over here. So yeah. So I don't know why they selected a hazard ratio of 1.13 for analysis. There must be some statistical measure for it, but that suggests that maybe a 10% difference was acceptable to them in terms of the risk of a recurrence. I think you brought up, I think you would want to know whether the recruitment was serial or whether it was done synchronously. I would want, as I mentioned, to know about the distribution of patients across the centers. I would want to know about the baseline demographics, age, sex, ethnicity as well, but also the breakdown of stage 2 versus 3 colorectal cancers and tumor nodal status. I would want to know a bit more about the inclusion and exclusion criteria involved in recruiting the participants as well. Moving on, I think we talked a bit about blinding. This is an open control study, i.e. it was not blinded / impossible to blind. Although I did mention that you could possibly give a placebo for 3 months on top of the intervention for 3 months. It's also quite interesting to find out why 3 months was selected as the duration of intervention for the adjuvant chemotherapy. Why not 4 months? Why not 2 months? Whether or not there was a biological rationale for that. In terms of the outcomes, I would say one of the strengths that we didn't mention actually was that this study is likely to have been pre-registered. That's because you can see that it's got an ISR CTN number. Now, many studies actually, if they are pre-registered, they are associated with an ISR CTN number. And this serial number really is registering the trial when it's put onto a trial database. So it suggests that the trial protocol was submitted beforehand and that the outcomes are likely selected a priori. That's a good thing because basically it reduces the risk of investigators going back after the data has been collected and trawling through the data to find a hypothesis that would generate some kind of significant result. So it reduces essentially the risk of post-reporting trawling, so to speak. I think the outcomes studied were clinical. They weren't surrogate measures or composite measures, which are very clinically relevant, especially because they looked at neuropathy or the grade of neuropathy. And in fact, oxaliplatin-containing therapies are notorious for causing peripheral neuropathy. So it's very good that they studied this clinically relevant outcome. And I think one of the other strengths of the study was that the study looked at patient-reported outcomes, so quality of life. So that in itself is very, very, very important clinically because it matters to the individual at hand that you may be seeing in clinic or following up or treating. One of the, I think some of the weaknesses or unknown bits of the outcomes that you could discuss are, first of all, we didn't really discuss, I didn't see in the abstract whether the attrition rate was reported. Even though we know that the study was analyzed intention to treat, they didn't really mention the level of attrition between the 3-month and 6-month arms. I would expect that attrition would be higher in the 6-month arm due to the longer course of chemotherapy. I think someone mentioned this, I think Katida, you mentioned that 3 years follow-up, you're not really sure why that was the case. And one thing I would want to know is why overall survival is not reported as well. And then the final 2 rows, bias and statistics. So I'd say one of the strengths was that confounders were controlled for in terms of the central randomization. I think also there was a reduced risk of funding bias because it was funded by large governmental bodies, as I mentioned. We mentioned that, I think Kale or Kantida, you mentioned that the physician's choice of treatment regimen was included there, and there may be some level of procedure bias as a result of that. And I mentioned about the bolus versus infused fluorouracil, whether that was controlled for in terms of the central randomization as well. In terms of the strengths of the study, in terms of statistics, I would say intention to treat analysis, as we talked about, and also the continued follow-up may increase the power of the study in the long term. And I also brought in, I had previously discussed why the inferiority margin for the hazard ratio was set at 1.13. So I hope that's helpful. Is that clear so far? Sorry for whizzing through that. Is that all okay? And
Yeah.
Any questions? Okay, yeah. So anyway, I'll just I would say that when you're commenting on the internal validity of the study, just to summarize, have these 6 rows: study design, population, intervention / control outcomes, bias and statistics, and then have a column for each of them in terms of strengths and weaknesses / unknown. And this is especially the case in the 20 minutes when you're reading through the article. Start having this table to hand and jot down points as you go along. All right, okay, let's talk a bit more about the ethical elements of the study. I think we only have 10 more minutes to go. Okay, so just briefly, does anyone want to comment on the ethical elements of the study? So let's hear from someone who we haven't heard from before. Ooh, okay, I have a question from Jay Tay. Is progression-free survival ever useful to measure in studies like these? Yes, it's definitely a useful study because really the role of adjuvant chemotherapy is to reduce the risk of recurrence. And progression-free survival, for those of you who aren't familiar with this outcome measure, is looking at the time to event. So survival is essentially a time to event measure. And you're looking at progression-free, which is, I guess, progression of the disease, so whether or not there have been additional metastases as well. So progression-free survival, in the context of adjuvant chemotherapy is very similar to disease-free survival. So after adjuvant chemotherapy, after primary curative treatment, where you resect a tumor, disease-free survival is the time to disease recurrence, and progression-free survival is also similarly time to disease recurrence. I think progression-free survival would be more useful in the context of individuals who already had a tumor that was not resected, and you're looking at whether or not there's been progression from, for instance, a localized tumor to distant metastases, or an increase in the nodal status of the disease. So I hope that helps answer your question. All right. So if there are no comments on what's the relevance of the hazard ratio? So let's talk about the hazard ratio. So a hazard ratio is looking at the risk of, for instance, disease recurrence in the intervention, which is 3 months of adjuvant chemotherapy, against the risk of disease recurrence in the control, which was 6 months of chemotherapy. So the hazard ratio here was 1.13. So essentially, they accepted that anything under 10% increase in risk of recurrence was significant. Was a significant result in terms of the two arms being similar or non-inferior to each other. I don't know if that answers your question, but the hazard ratio really is looking at the risk of recurrence in the control of 3 months versus the intervention of 3 months versus the control of 6 months. Chanel, does that answer your question? Okay, cool. So let's talk about ethics. I think when you discuss the ethics of a study, you should, I guess, talk about Beauchamp and Childress's 4 pillars of medical ethics. So I think I would structure my answer somewhat like this. So, in terms of the ethical implications of this, or ethical elements of the study, I would use Beauchamp and Childress's 4 pillars of medical ethics to try and answer or to try and analyze the ethical elements of the study. I would say that in terms of autonomy, this study was quite a patient-centered study because patients were allowed their choice of treatment. The consent for data was obtained. So I think if you look at the study, some individuals didn't consent to having their data. You can see here. So some individuals didn't consent for their data to be used. So the fact that they had considered consent for data reporting is good and respects patient autonomy. I think also the fact that the study focused quite significantly on side effects to the patients as a secondary outcome suggests that it was quite patient-centered as well. In terms of beneficence, it's likely that the study was reported in the interim because follow-up was still continuing. This was likely performed as the non-inferiority target or hazard ratio of 1.13 was met. And therefore, the study results were made available to patients and investigators as soon as possible. And this prioritizes beneficence. In terms of non-maleficence, I would say, which non-maleficence is really avoiding harm to patients where you can do. Because it was a non-inferiority study, really, the point of the study was to avoid excessive side effects to patients from extended chemotherapy, especially peripheral neuropathy from oxaliplatin. And then finally, justice. So I think the distributive of this justice of this study could be called into question because potentially resources were used up for the treatment and follow-up patients in centers or hospitals, which could have been used on inpatients who are not on the trial. The other thing is that, strength of the study is that because it was registered with a trial number, it's likely to have been approved by an independent ethics committee, probably from the MRC or Cancer Research UK or whatever. I think it's likely to have been quite ethical to begin with. Does that all make sense so far?
Sorry, can you explain distributive justice again, what it means?
Oh, right. Distributive justice is justice essentially relating, or fairness, so to speak, relating to the use of resources. So if if personnel or resources in the hospital are used for patients who are on the trial, it could be argued that those resources have been taken away from individuals who are not on the trial, who may have required the attention and time of doctors or healthcare professionals involved in the trial, or resources that were used in the trial that could have been used for those individuals. Whether or not that's right can be discussed, but that's an element of of justice that you can bring up in terms of discussing the ethics of the study.
So can you bring that point up for most clinical studies then?
You can do, yes. Okay, Tash has a question. I don't quite understand the non-inferiority. Okay, so so if you look at the abstract, let's go back to the abstract. So over here, you can see that they say that the study was underpowered, and follow-up is continuing over here. I think the reason why the study was underpowered is because the study protocol was initially meant for longer than 3 years, which we've talked about. They looked at 3-year disease-free survival, but I suspect that the study protocol initially was for 5 years. But the reason why they published this data was because this was an interim analysis that was done. Because at an interim level, the two arms were shown to be similar in results to each other. So if you look at what I've written here, it's likely because the non-inferiority target or hazard ratio of 1.13 was met. I think the hazard ratio was in fact 1.02 or something. That interim reporting was performed. And the reason for that is, and the reason this is a strength ethically is that benefit was already shown from 3 years of follow-up. Therefore, I would say that this study is, considered the beneficence of because it made these results available to oncologists as soon as some benefit was seen, which would then be applicable to patients with colorectal cancer who would be receiving adjuvant chemotherapy, if that makes sense.
Thanks. Yeah, I think that kind of makes sense. What is like a non-inferiority target there? I'm just a little bit confused with that.
Okay, sorry, I didn't actually discuss this, but non-inferiority is really looking at whether or not so this study really was looking at whether or not 3 months of adjuvant chemotherapy would produce similar outcomes in terms of recurrence to 6 months of chemotherapy. It wanted to see whether 3 months was inferior or non-inferior to 6 months of treatment. And the way they looked at that was by looking at the hazard ratio for recurrence. So if the recurrence rate was 10% more, or in this case, 13% more less than 13% more in the intervention arm, then 3 months of chemotherapy was considered non-inferior to 6 months of chemotherapy.
Okay, thanks. That's actually really clear. Thank you.
Okay, cool. Anyone else have any questions? So really, I mean, I think the aim of the study was to say, look, 3 months of chemotherapy is as good as 6 months as an adjuvant chemotherapy to reduce recurrence. And also it reduces the long-term side effects, including peripheral neuropathy and effect on quality of life. I think that's essentially what this abstract is trying to say. All right, let's tackle the final two questions because I think we are running out of time. But really, how would you explain these results to patients? So I would say, for instance, I was seeing a patient in clinic, or if you were seeing a patient in clinic, I would say, well, if you had someone who was aged 18 and above with so-called high-risk stage 2 and 3 colorectal cancer, if following surgery, you opt for 3 months of chemotherapy versus 6 months of chemotherapy, you're likely to have as good recurrence-free survival. So your cancer is, not likely to come back as much as it would be if you receive 6 months of chemotherapy. What that means for you is I would recommend that you have 3 months of chemotherapy as opposed to 6 months. And you are likely to have fewer side effects in the long term, including tingling in your hands and your legs, and loss of sensation, so on and so forth. All right. Are there any patients you wouldn't recommend the study to? Well, I think individuals who have, for instance, stage 4 colorectal cancer, so larger tumors, maybe you would want to have a longer treatment time, so 6 months, which is the standard of care, as opposed to 3 months because there's a high risk of recurrence. Or if you had stage 1 colorectal cancer, because you may require a shorter amount of time for chemotherapy as well. I think because this study, if you look at the funders, it was the MRC, Swedish Cancer Society, Cancer Research UK, whatever. The population is likely to be quite focused on the Western kind of population. So the generalizability of this population to, for instance, an East Asian, South Asian, so on and so forth kind of population is less generalizable. So I would want to comment, I wouldn't recommend it necessarily, or I don't think the results would necessarily be would be generalizable to a population that wasn't Western. And obviously, yeah, I think, individuals with multiple comorbidities as well, in terms of long-term adjuvant chemotherapy, and if they had, they were quite old, I would want to look at the exclusion criteria for the study as well. Would this trial change your clinical practice? So that's probably talking about the if you got a question like this, would this trial change your clinical practice? If you got this kind of question in your interview, what it really is looking at is the external validity of the study, i.e. the extent to which this study can be applied to the average population or an individual that you were seeing in clinic. So when you comment on the external validity of a study, talk about use the mnemonic G-step. I would say generalizability. So I'd want to know about the baseline demographics, likely Western population, as I mentioned. The tolerability, there's no mention of attrition rates, but I think 3 months of chemotherapy was likely more tolerable than 6 months. And I think in terms of looking at the efficacy and price, so efficacy, both in the intervention and control were as efficacious. They were non-inferior to each other. The price of the study of the intervention, so it's probably more pragmatic and cost efficient to implement a reduced course of adjuvant chemotherapy over 3 months, as opposed to 6 months. But I think importantly, what you would also say in terms of whether or not this study would change your clinical practice is, yes, this is a great abstract. It's got good internal validity. However, I'd like to read the full paper. I would probably do a quick literature review of everything that was out there in terms of looking at shorter courses of adjuvant chemotherapy compared to a 6-month course of adjuvant chemotherapy in stage 2 and 3 colorectal cancers. Once I've done this literature review, I'd like to do a meta-analysis looking at the results and try and see whether or not the other randomized controlled trials also showed the same effects or the same results. But overall, I think you probably have to give a stand whether or not it would change your clinical practice, and that would be what your interviewers would be looking to see. Is you taking a stand? And I would say yes. This actually is a practice-changing trial because it has, for the reasons discussed, it has many strengths in terms of its study design. For instance, it's a randomized controlled trial, multi-center across many different centers. And because the results are significant, and because it would overall improve the quality of patients' lives, and similarly, 3 months of adjuvant chemotherapy would reduce recurrence to the same extent as 6 months of adjuvant chemotherapy. All right. Any questions so far? Okay, I'll take the silence as a no. Does anyone have any general questions on critical appraisal?
I had a general question about the type of abstracts they might give you in an interview. Yeah. So obviously this one's a randomized control trial, and a lot of the time it usually is a randomized control trial, but are they also likely to give you something lower down the hierarchy, like a cohort or case control?
Yeah, they might do actually. They might give you a case control study. That's usually, I mean, it's not common, but they could give you one. I think there was 1 year where they had a case control study. They might give you like prospective cohort studies where you comment on that. And that's, I think you could comment a lot about that in terms of the study design and say, for cohort studies, you know, there are confounders that aren't kind of controlled for, so on and so forth. It's lower down the hierarchy of evidence. Yeah, I mean, to answer your question, it is possible to have other study designs. And I think what I would recommend to prepare for that is to have a pro forma for each of the different study designs. So have one for randomized controlled trials, which are most likely to come up, but one also for prospective studies like prospective cohort studies, and also one for retrospective studies.
Okay, thanks. And then the other thing I was going to ask was, are they likely to give you an abstract or a whole paper? Because obviously if they give you the whole paper, it's a bit harder because there's so much to read.
Yeah, I know. It's definitely not realistic to read the whole paper. They'll give you an abstract.
Okay, thank you.
I think the only other thing I would say is that if you're doing kind of a non-London AFP, especially I think for Oxford, they will ask you, well, I've heard they will ask you about a paper that you've read recently that's been interesting. So, I mean, in preparation for that, I would read the full paper, but, you know, yeah, beyond that, I don't think they would give you a full paper to read.
So for those paper, would it be like kind of, you know, the landmark practice changing papers, or just anything that you're interested in?
I think anything that you're interested in, to be honest. You can talk about a practice changing paper, maybe depending on your interviewer demographic. So if they were, for instance, an anesthetist, or you can't really predict it, but if you did bring something that you know, everyone kind of in various specialties knew about, then that could be advantageous, or it could be disadvantageous, whatever. For my interview, I talked about a non-clinical study. Actually, I talked about a machine learning scientific study, which I think they seem to like. So really, it depends on what you find interesting, I think.
Thank you.
Any other questions at this point? Okay, otherwise, I think we'll call this webinar to an end. Thanks for attending. I'd be quite grateful if you could fill in the feedback, because this will help, I guess, the organizing team as well as myself. But yeah, if you have any questions, I'm more than happy to take questions about the AFP interviewing process, what London AFP is like. I mean, just any question really regarding to the AFP application process. You can email me at my email address, which I'm typing here. Yeah, feel free to email me if you have any questions at all relating to the interview. I hope that was helpful. And I think these slides should be available online as well. So yeah, I'll send them over to the Becoming a Doctor team, and they should be able to distribute this to you guys. All right, thank you very much.
Thanks very much for your time.
Thank you very much.